Thanks for inviting me. So we're going to talk about neuroPASC, post-acute sequelae of COVID-19. And you see my affiliations there. I actually used to work at the ADRC, but it's a long time. So, yeah, they kicked me out of the ADRC a long time ago. All right. So many of you have seen long COVID in the news, pretty high profile in the US and overseas. So it's made a significant impact at the non-expert level, but I'm going to talk more about the expert level stuff. You know that you've hit the headlines when you get a TEDx talk about a topic. And this has affected some pretty high profile people. Okay, so this is from one of the very, very early reviews after the pandemic began, of the reported symptoms and some findings of long COVID. Although I'll spend a little bit of time on dysautonomia, I'm going to spend most of the time on cognition. So just by way of getting started, this is a really heterogeneous. Oh, I should also mention, it's okay to interrupt me. I've got a ton of material to cover and a lot of slides, but I'm happy to be interrupted and to skip past some stuff that's not absolutely necessary. So, yeah, very non-specific, heterogeneous, depending on which study you look at, symptoms and signs. A lot of papers mention that the findings and signs are similarly non-specific as in chronic fatigue syndrome, also known as myalgic encephalomyelitis. And there are a couple of caveats when thinking about this. One being that when people survive a severe medical illness of any kind, but in particular infections, whether they're bacterial, viral, or otherwise, it's quite common that they suffer neurocognitive and mood alterations. So this is not unexpected. Other viral illnesses are known to be associated with neuroPASC-like symptoms and disabilities. And even the other coronaviruses are known to produce neurological complications, including chronic ones. Epidemiology is really hard to talk about because of the heterogeneous and non-specific symptoms and the differing variant definition across studies. In addition, there's tremendous amount of bias. As you can see, there are some of the sources of bias, one of the most common being referral bias. Some studies look only at symptoms, some look at objective findings only, and some look at both together. So it's a lot easier to ask, rather than how frequent is this, how frequent is neuroPASC among the other symptoms that occur in patients with long COVID? And then how prevalent is it after COVID as compared to other respiratory viral infections like influenza? So here is a large symptom survey of a pretty wide range of symptoms that are often associated with long COVID. Over 10,000 participants in this meta-analysis. And you can see here that although cognitive deficits or cognitive complaints and complaints of memory loss are fairly common, that they do not equal the prevalence of things like shortness of breath and fatigue, but they're comparable to things like anosmia. This study, for reasons I'll show you in a moment, is clearly a referral bias study because the vast majority of people in the study had at least one COVID symptom. This just arrived in my inbox this morning. Published in JAMA, looked at medical records from over 1 million individuals who had had COVID, and following acute COVID, they looked at 1 or 3 symptom clusters: fatigue, respiratory symptoms, and cognitive symptoms. One of the distinguishing features of this is the prevalence in this study was much lower than in many of the studies that I'm going to talk to you about. That's probably attributable in part to referral bias in the other studies. This was meant to be a survey of anybody who had acute COVID. But notice that the cognitive cluster was actually quite uncommon in this particular study. But it is in accord with many, many other studies showing that women seem to have a higher prevalence of at least the complaints associated with long COVID. So I mentioned female sex as a risk factor, older age. We're going to look at some studies that evaluated some of these risk factors, so I won't go into great detail here, but I'm also going to talk about whether acute COVID severity predicts the likelihood of long COVID. There is a strong connection to olfactory and gustatory abnormalities, vaccination status, and then comorbidities you'll see cropping up. So here is incidence of one or more of a variety of symptoms often attributed to long COVID. This is risk ratios for developing PASC in different flavors versus matched controls who had not had COVID-19. And there were some biases, as you can see here. These patients sought medical care, so individuals who did not go to the doctor were underrepresented or not represented in the study. And clinicians knowing something about post-COVID might have been more likely to report the COVID-associated symptoms in the COVID patients than in non-COVID participants. In any case, you can see age is a prominent risk, older age is a prominent risk factor for the neurologic conditions, neurologic manifestations of long COVID, smell and taste, another risk factor, and you see risk ratios for some of the other common long COVID symptoms. Contrary to popular belief, PASC generally does occur in children, but the rates are much lower than in adults. In this study, looking at all long COVID symptoms, only 6% of kids had this. These were actually mostly very young kids. So this would have meant that the reporter was the parents or caregivers to the kids rather than the kids themselves. It's possible that parents were not sensitive to things like cognitive impairment, but you can see mental fuzziness is pretty low on the list. Of course, it's kind of hard to identify mental fuzziness in a 3-year-old. So worth mentioning that you can get COVID after you've been infected. In fact, it's a cumulative risk. So if you look at neurocognitive, after one infection, two infections, and three or more infections, you have a higher cumulative risk with the more infections you get. COVID does, or long COVID does happen after vaccination, but the rates are much less when you get acute COVID if you've been vaccinated than occurs in unvaccinated people. And this is very robust across multiple studies. In addition, it doesn't matter how long it does matter, but vaccines are protective whether they're recent or longer ago. And the take-home message of this study was that whether it's Omicron or Delta that you had, or one of the ancestral strains, if you've had a vaccine more than 6 months ago or between 3 and 6 months, you got a pretty low odds of getting long COVID. If your vaccine is more recent, where you don't have as much protection, perhaps the rates are somewhat higher, but still considerably lower than people who are unvaccinated. So let's talk about the clinical manifestations, and I am going to focus mostly on objective testing rather than simply patient-reported symptoms. So this is one of the earliest neuro-COVID focused studies that comes out of Northwestern, Igor Koralnik, very early after the COVID epidemic started getting referrals in February 2020, at a time when tests for COVID were not as available as they are more recently. So they took patients either who had a positive PCR during acute illness. Some of them had typical symptoms and were diagnosed by providers with COVID, but did not have confirmatory laboratory testing. So this is a study where they looked at their first 100 consecutive referrals. They had had symptoms consistent with long COVID for at least 6 weeks. On the physical neurologic examination, there were relatively few objective findings, particular sensory abnormalities, but much more prevalent were objective deficits in memory and attention. And they didn't really differ for the PCR positive and the unconfirmed cases. They did not have a control group here, so they looked at how their performance on neurocognitive testing was compared to normative data. And both the PCR and the lab negative group had, by the way, just to emphasize, this is not a group of patients who had laboratories suggesting that they had not had COVID, but rather did not have the test done. In any case, both of these subgroups had impairments in attention and working memory, according to the NIH toolbox. The difference was not, or the effects were not significant in the lab group, but were in a similar direction. So we have done a COVID study here at UCSD. This is an effort spearheaded by Jen Graves, who's one of our neuroimmunology people, but we have a long COVID working group that meets every month. There is also at UCSD a general, not neuro-focused, long COVID working group. So a lot of activity going on at UCSD. In any case, this is UCSD's contribution to the neuroPASC literature. And the assessments were basically remote, with the exception that they could see some people in person for a physical neurologic exam. And there were two groups. Jen Graves is interested in people who have MS and other pre-existing neurologic conditions, but there was also a group that did not have a pre-existing condition. Probably the most interesting finding of this study is that at the first follow-up visit, about 4 months after the acute infection, the predominant symptoms were fatigue and headaches. And the most common physical exam findings were cranial nerves and limb and gait ataxia. And this is an interesting symptom or sign cluster that was identified at UCSD basically by Jen Graves that I've not seen reported in a lot of other studies. So the MoCA was impaired in 39% at 6 months. Symptoms were memory impairment and decreased concentrations instead of fatigue and headaches. So a pretty big shift in the predominant complaints. MoCA scores overall improved, but at least half of patients showed no improvement, and some of them showed worsening. About a third reported that their neuroPASC symptoms had resolved. As I mentioned, that the cohort with pre-existing neurologic and no pre-existing conditions were pretty similar in complaints and findings, and perhaps most relevant to Jen Graves's interests, there was not a worsening of their MS and other pre-existing conditions following COVID infection. There are so many published neuropsych testing studies, it's impossible to review them individually. And in fact, this number is over 100 now. Since I made this slide, it's just incredible number of publications. I should also mention many of them are of very poor quality, but I've tried to pick out ones that are of better quality to tell you about. Wide range of impairment rates, probably due to varying ascertainment methods, whether it's a MoCA versus more comprehensive neuropsych testing. In any case, the patterns that are typically seen are problems with executive function, free recall, and processing speed. With cueing, these patients do have better recognition memory. So this is more a retrieval deficit than rapid forgetting. And with continued follow-up, most of these studies reported improvement, but a few reported some decline. And I'll show you one particular outlier study in a minute. To my mind, this is the single best available study. It's from the UK Biobank. This study has been going on for a long time and has the advantage that participants were enrolled before COVID infection. So they have baseline assessments, including neuropsych and brain imaging. I'll tell you about the brain imaging later. but compared to their pre-morbid, pre-COVID, I should say, performance, there were decrements in the COVID group on both trails A and trails B. So speed and kind of executive function, processing speed. Worse changes, meaning increased time to finish the test in the post-COVID as compared to the control patients. This is a longitudinal study. These guys are developing longitudinal data, but it's not available yet, or they haven't published it in any case. This is a post-hospitalization study looking at longitudinal course. Important to mention that it's post-hospitalization because obviously there's no representation of people who had milder COVID. This study included individuals who had during acute COVID had neurological disorders, the most common of these being a toxic metabolic abnormality and stroke, and some even had hypoxic ischemic brain injury, presumably from hypotension and global cerebral hypoperfusion. So they looked at a disability scale, an activities of daily living scale, and a telephone Montreal Cognitive Assessment, or MoCA, and also the toolbox, NIH toolbox neuro quality of life assessments. So at 12 months after COVID, most, in fact, the vast majority of these people had at least one abnormal metric on this battery of assessments. The most common was an impaired MoCA score. Range is up to 22 for the telephone MoCA. And the disability and activities of daily living did not improve in about 50% of the patients. And interestingly, the differences in the disability were no different in the patients who had neurologic complications during their index hospitalization with acute COVID than those who didn't have those neurologic complications. I found that quite surprising. These are just a plot from that same study of how many people got worse between 6 and 12 months after their hospitalization. And let's see, unchanged on the modified Rankin scale and the activities of daily living scale. A lot of improvement on the MoCA score. So that's some positive news for PASC, neuroPASC at least. This is the outlier study that I mentioned earlier. It did focus on people with mild COVID. However, major referral bias, because they were all referred for a research study where it was known ahead of time that neuroPASC was the primary variable of interest. They did a pretty good job covering a range of areas, including subjective reports, objective testing with the COG state battery. You can see the domains that are represented in that battery, notably executive functioning and delayed recall weren't assessed by this battery. They also looked at olfactory function using an objective smell test. So they found at the early time points, there was mild to moderate cognitive impairment in about a quarter of patients that was associated with inability to return to their pre-COVID work levels. and that lasted for up to 4 months after their acute COVID infection. Interestingly, the neuro-COVID impairments were not related to the acute COVID severity, which was a limited range in the study because they all had mild COVID, nor were the neuroPASC problems related to measured lung function or reported comorbidities, including anxiety and depression. The sort of outlier aspect of this study is the overall decline in performance in all of the study participants. The rate of impairment, according to normative data, there were no controls in this study, increased from 2 to 4 to 12 months post-diagnosis. And it didn't matter whether you were impaired by MoCA on the by the cog state battery at the initial 2-month assessment or were unimpaired, all of them deteriorated. So that differs pretty squarely from some of the other longitudinal studies I told you about. I have just one slide about clinical labs that have tried to look at, things that are commonly measured by clinicians, either during hospitalization or after, to look for things like inflammation and changes in CSF parameters. And I have 2 slides. So blood-wise, no differences in C-reactive protein levels, a very modest effect for higher D-dimer, which is a marker of coagulation and inflammation, higher levels in the post-COVID group than in controls. This was a Yale-based study. And then borderline for the CD4-CD8 T cell ratio. In the spinal fluid, the only difference, and again, it was pretty modest effect, was a shift in the lymphocyte to monocyte ratios towards a predominance of CSF monocytes. This study was pretty unusual in getting spinal fluid. Most studies don't do that. But there's a tremendous amount of activity and publications in the research biomarker domain. So I can only show you a selection of those. This is the combination of those Yale folks with the Mount Sinai group. They did a cross-sectional study. This was relatively early in the pandemic, so before Delta and Omicron. They looked at 215 participants, had 3 comparison or control groups, including a group that had COVID, but didn't report post-acute sequelae of COVID, and then a long COVID group. They were studied about 1 year after illness, so these are pretty long-term effects. Again, these are referral cohorts, which you can kind of tell from the very high rates of a variety of things, including the neuro-COVID symptoms, brain fog and memory difficulties, and confusion. POTS symptoms were quite frequent as well, almost 40%. That POTS is postural orthostatic tachycardia syndrome. And for those of you who are not familiar with it, it's a pretty self-explanatory name for a condition. When people stand up, they get tachycardic, they get dizzy, and they want to sit down. So this really limits activities, and this is a very, very disabling feature of long COVID that I'll talk about a little bit more in a moment. So they found that the patients with these symptoms including fatigue, if you want to characterize that as a neuroPASC symptom, had low levels of cortisol, but normal ACTH, suggesting that it was not a hypothalamic effect, but more an end organ effect on the generation of cortisol. They also had lots of exhausted T cells. There's pretty big literature on exhausted T cells in a number of viral infections, including HIV. These cells are basically ones that should have been fated to be pruned from the pool of T lymphocytes, but for a variety of reasons, they express cell surface markers that protect them from removal. And unfortunately, they're bad actors in the sense that they produce chemokines and cytokines that the brain doesn't like. So they've been causally connected to a variety of neurological problems. They also found a lot of Epstein-Barr virus reactivation. So looking at blood for markers of Epstein-Barr associated proteins. And this, some of you are probably familiar with the recent, very, very compelling publication about Epstein-Barr virus reactivation or new infection as a risk factor for subsequently developing multiple sclerosis. These findings are pretty common in chronic fatigue syndrome patients, so another parallel between long COVID and chronic fatigue. They also looked at some markers of immune activation, inflammation in the form of CD4 and CD8 T lymphocytes that were producing IL-4 and IL-6, found those to be elevated in the long COVID patients compared both to the healthy controls and to the post-COVID patients who did not have neuroPASC or other PASC-related symptoms. And this is just a demonstration of that cortisol difference. It actually did quite a good job, as you can see on the ROC curve, identifying or discriminating people who had long COVID from those who didn't. This is just the data that were presented in the paper on the viral reactivation. And so basically they looked at immune reactivities against both the SARS-CoV-2 antigens and these other viruses. I know you can't read this, but I'll just describe it for you. So as you might imagine, people who were COVID convalescent controls didn't have PASC symptoms, had a very high rate of increased reactivity to SARS-CoV-2 antigens. But what I've got the arrows pointing at here is the Epstein-Barr virus antigens elevated in the non-PASC post-COVID patients, but in 3 clusters of long COVID patients, all of whom had prominent neurologic symptoms, there was an uptick in reactivity to Epstein-Barr virus. There was not a similar increase in reactivity to other herpes viruses or to influenza viruses or some of these other viruses that they looked at. So let me introduce to you a combined biomarker and imaging study of PASC. This study looked at mild illness, mild acute illness. They did not have a control group, so they used local normative data again. They reported primarily on the Ray-Osterrieth complex figure copy, so not the recall after a delay, but the copy. And 26% of the people in this study were impaired on that measure. Most of them were unable to return to work at their prior level. They found a variety of biomarkers were upregulated in plasma, and many of these were associated with impaired performance on the Ray-Osterrieth. And you can see they did a pathway analysis and found that there was a plausible association with the neuroinflammation signaling pathway and IL-17 signaling pathways. Let's see. This is just a depiction of the Violin plots for the different biomarkers, and curiously, the red ones are actually the non-significant ones. Okay. This is an extremely complex study because of the number of different dependent and independent measures that were used, which obviously raises the issue of false discovery. In any case, 309 patients after acute COVID, 457 non-COVID controls. They identified using cluster analysis and machine learning 3 clusters, one of which was neurological, that represented 25% of the group. And you can see the list of the neurocluster symptoms, which featured memory and concentration problems. This study replicated the prior studies' finding of low cortisol levels as a feature of PASC. And additionally, and unique to the neurologic symptom cluster, there were abnormalities in circadian rhythm markers. This is one of the only studies I could find that actually looked at circadian rhythm markers. I mentioned that they had a huge number of variables that they measured. Just to summarize, they also found that neuroPASC or PASC generally was associated with autoantibodies that you see listed there, EBV and cytomegalovirus, viremia, diabetes, and also a higher SARS-CoV-2 virus RNA in blood. This only looked through 3 months of follow-up. The controls didn't get the symptom surveys, and as I mentioned, a high probability of false discovery. They tried to correct for some of these in the individual domains, but not across the entire study. Okay, so to move into longitudinal biomarkers, this is a study that looked at mild COVID for the most part, 52 PASC, and these were all neuroPASC patients, 69 non-neuroPASC. They had an early recovery and a late recovery time point. And in order to meet their criteria for CNS PASC, you had to have one of the symptoms from the list that you see here. If I remember correctly, these folks did not do objective testing, this is just symptom report. They did measure a variety of markers of inflammation, chemotaxis, and astrocyte activation, glial fibrillary acidic protein, or GFAP, and a marker of axonal degeneration, neurofilament light, that is commonly elevated in many degenerative neurologic conditions, including Alzheimer's disease and ALS. So a couple of take-homes. Both of these inflammatory markers, IL-6 and TNF-alpha, were elevated in blood pretty significantly at both the early and the late recovery time points. They did decline a little bit, but remained quite elevated, and the decline was not statistically significant. GFAP was elevated at the early, but not the late recovery assessment. This is the study I mentioned earlier. That's an outlier in finding a lot of deterioration rather than recovery over time. And the major difference here from other studies is that they looked at this tryptophan degradation pathway. You may know that tryptophan is a precursor to serotonin. So reductions in serotonin can be associated with depression and fatigue and other things. Abnormalities in this tryptophan kynurenine pathway are seen in a whole bunch of other viral illnesses. And some of the, so basically what happens is the myeloid cell, so the innate immune cell activation contributes to a shift away from serotonin and toward these other tryptophan metabolites that have neurotoxicity and vascular toxicity. So they observed a correlation between higher levels of these bad kynurenine actors in the patients in the decline in cognitive performance. Okay, neuroimaging. Lots and lots of studies. I got about 14 minutes left. So I will power through these in order to give a little bit of time for questions at the end. Very quickly, this one, this is that Ray Osterrieth study. They found, interestingly, increased white matter volumes in the regions that you see here, subgenual corpus callosum and the cingulum. And they, in order to help interpret, or they interpreted this unexpected increase as perhaps reflecting similar increases that occur in multiple sclerosis patients when they are having an MS exacerbation and they have neuroinflammation. They did find some correlations between, on an FDG PET imaging, between poor performance on the Ray Osterrieth copy and increased uptake, again, somewhat counterintuitive, in the left inferior temporal gyrus and occipital gyrus, but reduced uptake in the right dorsal anterior cingulate. Okay, I did want to mention a study that looked at the autonomic nervous system, very different anatomy from the voluntary motor system. So the autonomic nervous system is subserved by the hypothalamus, autonomic nuclei in the brainstem, and autonomic nuclei in the spinal cord as well. And it influences things like vascular smooth muscle reactivity. It innervates cardiac muscle, perhaps explaining some relationships to tachycardia. And then it also innervates the enteric nervous system, the intestines. Some of the brain regions that have prominent input to the autonomic nervous system are subcortical structures like the thalamus and some limbic system structures. So this was an interesting study I found pretty compelling that uniquely focused on the autonomic components of PASC. So everybody in the study, there were only 9 patients, had fatigue, brain fog, and orthostatic intolerance. They were studied at a rather long time point after their mild COVID-19 infection. They were compared to a POTS control group and people who were healthy. They had a very large number of measures, including some simple ones like doing a Valsalva maneuver and looking at heart rate in response to that. Some tests of sweating, tilt table tests, changes in cerebral blood flow velocity with changes in position, blood, carbon dioxide measures, skin biopsies for small fibers, and just to make the connection between small fiber neuropathy and autonomic dysfunction. Both of those systems involve small fibers, so small, either lightly or unmyelinated nerve fibers that subserve pain and autonomic function, and are in many disorders, the two are affected concomitantly. They also looked at some immune markers. I won't dwell on this except to say that the POTS group and the PASC group were very similar in their symptoms, and both were highly statistically significantly different from the healthy controls. This is the main finding that I want to focus on, which is that both the POTS group and the PASC group had a reduced cerebral blood flow response to the tilt table test. So in controls, you can see that their blood flow remains about the same, whereas in the other two groups, it reduces significantly. And it's sort of reasonable to believe that having a reduction in cerebral blood flow might explain people feeling dizzy and having brain fog, confusion when they stand up. Interestingly, there was a difference between the POTS patients and the PASC patients in that carbon dioxide levels in the POTS group changed. They actually decreased, and the significance of that is, that's a normal response to hyperventilation, for example, is vasoconstriction. And vasoconstriction is one of the things that induces a reduction in cerebral blood flow. So when you corrected for the blood CO2 content, the POTS patients looked much more like the controls as compared to the PASC group. Let me skip past this just in the interest of time, just to say that there were all differences. Also differences in the epidermal nerve fiber innervation in the skin. This is just summary of what I just told you. This is another study that corroborated the abnormalities in cerebral vascular reactivity in response this time to an acetazolamide challenge. Lots and lots of structural brain imaging studies. And again, in the interest of time, I'll just summarize by saying that a common theme in all of these studies is that many of the areas that are affected have prominent connectivity with the olfactory bulb and olfactory system. To put that in context, you probably know that acute COVID infection in many cases kills off the neuroepithelial cells in the nose, and that is thought to be the underlying cause of smell changes. And so this connectivity with the olfactory bulb is maybe understandable in the context of those smell changes, and perhaps is consistent with the degree to which smell changes. I didn't spend a lot of time on that earlier, but smell changes do predict long COVID. The biobank study that I mentioned earlier with the pre and post assessments, again, they had pre-COVID imaging and post-COVID imaging. Patient is their own control, non-COVID controls as well. And there were changes in volume. In this case, again, counterintuitive, increases in cortical thickness. That's typical for older controls for reasons that are not clear to me. But those same changes did not happen in the post-COVID group, were different from the post-COVID group. So I'm going to skip back this. The FDG PET imaging also showed prominent effects in regions that are linked to the olfactory system. In many cases, these changes in structural and functional imaging measures do show correlations with inflammatory cytokines. And so let me just spend 2 minutes on underlying pathophysiology. So proposed mechanisms: why does a respiratory virus lead to neurological complications, systemic inflammation, CNS specific immune activation and inflammation, and endothelial injury, which is highly relevant to what Mark was talking about earlier. A lot of controversy about whether the virus can actually infect the brain. As Mark said, there's good evidence for astrocyte infection, not good evidence for neuron infection. A lot of people can find viral proteins and RNA in brain tissue. However, these are acute cases who died, and so that's plus minus relevant to long COVID. And finding these things does not necessarily mean infection. There is one study that looked at double-stranded RNA, had some evidence of active viral replication in neurons. And let me skip past all the rest. So lots of studies showing parallels between changes in a variety of things like microglial activation and hippocampal neurogenesis in both humans and mouse models and hamster models of COVID infection. This is just a slide. Maybe I'll let Mark comment on what he's been looking at, but just demonstrating that there are abnormal fibrin amyloid clots, abnormal mitochondrial function. And I apologize, Mark, if this is yours, I forgot to check that. I don't think it is your paper. And then there's blockage of small capillaries leading to potentially low oxygen carrying capacity to the brain. There are a number of studies looking at treatments. None of these at this point is randomized, placebo-controlled, double-blind. They address a whole bunch of different pathways, all the way from inflammation to simple symptomatic treatment with stimulants. And there are also some non-pharmacological interventions that have been proposed. Ongoing studies. So if you got patients who meet criteria or you think might have neuroPASC, you could refer them to a study. And I won't belabor with a summary and some open questions, but just open it up for questions from you all.